Hi, my name is Lauren Perlman. I'm a respiratory therapist here at Boston Children's Hospital, and today I'm going to be introducing you to the Triology 100 ventilator made by Philips Respironics. And the purpose of this video is to allow those caring for children in the community that are on this device to have an option to review what you've learned prior to being discharged from the hospital or long-term care facility, and help review for your nurses as well at home the different modalities that this device can provide for your children. I'd like to review with the Triology with you today and go over some of the features, and then we'll go over the different capabilities because it does have many different circuit configurations, and depending on what your child is using, it'll be set up differently. So let's look at the machine. This is the Triology 100 ventilator. We have a green light here that shows us that the machine is plugged into external power. So important to note that when you glance at the device, you see that you're plugged into wall power. Of course, that would be dependent on a generator, etc., but you know you're plugged into the wall. This is the main power button here. This is the alarm silence button. And this button will show you both yellow and red. Yellow indicates a low priority alarm, and red indicates a high priority alarm. They sound different as well, and we'll get into that in a little while. The menu buttons are here. We have menu up and down, and we will see displays here of what we need to do with these buttons and how to get into our menus and change the settings. The machine is about 14 pounds. The machine comes with a carrying case so that you may use it for travel outside of the home. There is a stand available, but typically the equipment companies that provide the ventilator for you won't be providing that for you in the home. So it will be sat next to the child on a table. It can be mounted onto or hung from a wheelchair, for example, for mobility. Let's turn the machine around. On the front left side, we have a place where, for those of you that are familiar with BiPAP technology, there's a smart card. So the home care company or durable medical equipment company that provides this for you can see if you're using the device. So it's important that they see that it's logging hours. This will not provide clinical information for you about your children. On the rear of the machine, we have a simple inlet filter, black, that will get dusty and need to be cleaned. If you wash it with water, please dry it before you put it back onto the machine. The company will provide you with additional filters. Here we have a place for oxygen to be put into the device. So this disposable, potentially breakable piece should come with the machine and snaps into this port by pushing the lever on the top. If you want to remove it, you have to push to remove it. This is where oxygen tubing will go, that will go to your device that provides you with oxygen, whether it's a concentrator, a liquid system, or a gas tank. And parents always say to me, how much oxygen do I know how to provide into the ventilator? You will have a prescription for your child for liters of oxygen for different devices. It might be for a nasal cannula during the day when they're off this device. It could be for a heat moisture exchanger for the tracheostomy tube when they're off the device, and for the device itself. The prescriptions typically are liter flow. My preference would be that the physician order a range for you. Oxygen for your particular child could be 0 to 4 liters per minute into the Triology ventilator so that you achieve a saturation on your oximeter or saturation monitor between, say, 92 and 95%. Each prescription will vary depending on the child's needs. So that the fact that you have 0 at one end means that if your child's oxygen saturation is high enough and meets criteria for the prescription, you can turn the oxygen off. So adjoining the oxygen adapter, we've already been through the filter. There are a couple of adapters here for long-term batteries and downloading of information, which is not something routinely provided for you in the home. The long-term battery may be provided depending on where you live and how far you live from the location of your durable medical equipment company, and depending on the needs of the child, whether it's 24/7 that they're on this support or just at night for sleep. Over here, we have a removable battery. I can press the button and I can see that this battery is full based on the green lights. This is approximately 3 hours of use. Within the machine is another 3 hours of use of power, battery power. So in total, this snaps in and we have 6 hours of use of life for the machine. These adapters here are used when the ventilator is being used with an active circuit with an active exhalation valve, and I'll show you that in a moment. If your child is not on an active circuit, but rather on a passive circuit, you will have a solid blue piece here, and these two pieces will be missing. You can see on this other side of the machine, we have our power, main power plug that goes right to the wall, and we have the gas outlet where the air comes out to go to your child's mask or tracheostomy tube. The majority of the durable medical equipment companies do like you to use a filter on the outlet of the gas flow. This filter is changed typically weekly or every 2 weeks, but keep an eye on it because it can turn dark, and it has nothing to do with the cleanliness of your home. It may have to do with the type of heating system or if the windows are open and it's allergy season. So just keep an eye on this. If it gets dark, change it and let the company know if you need more than they provide for you. So here we would attach our tubing. For the active circuit, which has an exhalation valve in it, this would be primarily used for a tracheostomy patient, but not necessarily. We have the circuit here, which has an exhalation valve in it, which will open and close between the breath cycles. The patient gets attached to here with a form of adapter. This would be an adult type adapter because it's larger and longer. This would be a pediatric adapter. And please do discuss this with your physicians, your respiratory therapist, about which is best for your child. It depends on the size of the child and the size of their breaths. If we put a really large piece here, if you look, if here's where the child is and here's where the fresh gas is, the child has to rebreathe this air, which is sort of like breathing through a paper bag. So small babies with small sizes of their breaths, we use small pieces, and larger patients have the flexibility. Obviously, if this is connected here to my neck, I would like a longer piece. It would be easier for me to roll around on the floor if I were an infant if I had more flexibility. Unfortunately, we can't always provide that for your children. For the purpose of today, this is our child. The ventilator circuits come with heated wires to minimize water rainout in the tubing and maximize smooth airflow delivery to the children, and some come without. They have many different circuits, pediatric and adult size. For the purpose of this demonstration, we have a pediatric tubing that we're going to take the air from the machine and put it through a humidification system. This one we're using today is the Fisher-Paykel humidification system. There are many on the market, so it depends what your durable medical equipment company would provide for you. But this will provide heated humidity, so the cold, dry gas comes out of here, passes over the warm water, which would be fed by a bag to keep it at a certain level, and then we would deliver the air to our patient. So with regard to the Triology active circuit with an exhalation valve, we have the main gas flow coming out of the machine, going through the humidifier and out the other side. Now you see there are two other hoses here. And if we follow the hoses, we'll see that one of them goes to the exhalation valve and one of them taps into the side of the hose. This is where the machine sends information about what's going on with the child, as in pressure, for example, within the circuit. It also gives information to the machine to be able to work with alarms. On the machine, one is fatter than the other, and so they fit accordingly onto the two ports that I showed you earlier on the back of the machine. So we're talking about active circuit now because we have an active exhalation valve. I'm going to turn the machine on. So what we see now on the face of this machine, we see that we're in the pressure control SIMV, or synchronized intermittent mandatory ventilation mode. Common modes that your child might be using could be volume control SIMV, pressure control SIMV, could be the assist control mode for volume or pressure. This device offers all of those different modes of ventilation. For the purpose of this video, we are in pressure control SIMV. So that means that when I look into the menu, so up arrow is the menu, and I look at settings and alarms and select them, I can see that the mode is pressure control SIMV as it states up top. This patient has an inspiratory pressure setting of 25 centimeters of water, PEEP or end expiratory pressure of 5, pressure support, and it states for you above PEEP is 12 centimeters of water. Sometimes there's confusion about the language with pressure support. So this machine clearly tells you that it's 12 centimeters of water over the PEEP. So we're watching here this bar go up and down and show us the pressure and the baseline pressure, the PEEP, of the breast that the machine's delivering right now. You can see that the mandatory breaths, which are 8 breaths a minute for this child, when one of those synchronized IMV 8 breaths fires, it goes up to a pressure of 25 and releases down to the PEEP of 5 as it's been asked to do. In between those 8 breaths, this patient can use the pressure support breaths, which we talked about are 12 centimeters above 5. 12 plus 5 equals 17, so we'll see the number go to 17. 17.5, 17.5, and when it's time for an intermittent mandatory breath of the 25 over 5, the peak inhale pressure 25, the PEEP 5, we see the manometer here go up to 25 of pressure. What you might notice is that the machine is counting breaths per minute. So 8 breaths a minute is what the machine is going to deliver regardless. And your child can take as many spontaneous breaths with the pressure support in between those 8 as they desire. Those are the breaths that will go up to 17 and down to 5. How did we come up with these numbers? Well, obviously your child was on a ventilator before they went out into the community, so the hospital did determine what support was appropriate. And what the hospital looks at, and the doctors in the hospital look at, is the size of the breath and how efficiently that works for that child's particular size body frame. So we can see that the machine measures respiratory rate, 19 breaths a minute right now. Tidal volume, VTI, that's the tidal volume that the machine's delivering to your child. And you'll see that the large ones, the mandatory breaths, that go up to 25 and down to 5, measure over 400 cc's of air, but yet the pressure support breaths, which are up to 17 and down to 5, they are less pressure and therefore smaller, measure in the 200 range. So we see some breaths that are 400, some breaths that are 200. And that's something that gets confusing to caregivers in the home at times. Why do I see 2 different numbers? And why, when the child goes to sleep, do I only see the 400s? And do I only see 8 breaths a minute? Well, perhaps when the child goes to sleep, they're not initiating those pressure support breaths in between the 8 mandatory breaths. So certainly if you have any questions at any point in time with your child on life support in the home, please do contact your physician and ask questions about what you see. The machine is also giving you a peak flow rate here. That it determines on its own, nothing for you to be concerned about. What the machine does, and this is true for all ventilators, they look at the size of the breath and how many breaths you take, and they multiply it, and that multiplication goes on over the minute, over the minute, over the minute. And the size of the breath times how many breaths equals a term that we call minute ventilation. And here you see minute ventilation, or the abbreviation for it. So our patient now, who has 8 mandatory breaths that go up to 25 and down to 5, doctor prescribed, and in between those 8 breaths, our patient can use pressure support, which helps them overcome resistance of breathing through a tube, for example, and perhaps they have some issues with their lungs, which is possibly why they're on the ventilator. They need a little help with breathing. We give them what we call pressure support, otherwise known as BiPAP. BiPAP is a term we use when we see a mask on a face, like this. A mask on a face typically means BiPAP. A tracheostomy tube in the neck into the lungs, the same BiPAP is referred to as pressure support ventilation. So our patient has a mix of pressure support and mandatory breaths of 8 breaths a minute. So this machine is watching for us all the different numbers. It's watching the amount of air in a minute and the breath rate. Another thing that we see on the face of the machine is this little black dot. See the little black dot? That means that the patient or your child triggered that last breath to turn on. So that is a trigger light and shows us. So during sleep, deep sleep in particular, it's possible that that light will not shine up if the patient doesn't take that last breath on their own and trigger it with their inspiratory force and muscles. And that's something you can also discuss with your physician. If you feel that your child should be triggering a breath but isn't, or did last week and doesn't now, that's something else to look at. So we see the trigger of the breath, we see the pressures that that breath generates, we see the tidal volume or the amount of air that comes out of that breath. We see how much air in a minute that child is utilizing for their life at that time. So when children are up and awake and watching TV, stimulated by therapists and whatnot, they tend to breathe faster. So if you watch, the minute ventilation number may be higher when your child's awake and active versus when they're asleep and relaxed. I always ask parents that I work with and caregivers I work with to please know your child's breathing rate and heart rate, awake and asleep. That will help you to guide you as to when they're well and maybe when something's not quite right. Other numbers that you can watch when your child's on a pressure type of ventilation, as we have here, is the size of the breath. If the tidal volume and the minute ventilation seems to be going down, it may mean that secretions are building up and they're receiving less air per breath because mucus is building up and they might need to be suctioned. There are obviously many ways in which you can tell if your child needs to be suctioned: by putting your hand on their chest, by hearing a cough, by noticing perhaps a saturation change if you're looking at the saturation at that time. So other numbers that you observe when you watch your child utilizing the Triology 100 ventilator in the pressure control SIMV active mode, a circuit with an exhalation port in it, are these numbers in this second box. We see the PIP, that means the peak inspiratory pressure, and that should show us approximately the 17, which is the top pressure for our pressure support breaths, and also 25 for the top pressure of those 8 mandatory breaths that our patient is receiving. In addition, below you see something called mean airway pressure, or MAP, 9.9. That is not something you adjust. That's something that helps caregivers like myself to note how much support cumulatively this device is providing for your child. The higher the number, the more support on the ventilator. This is a ratio. It says IE ratio. This is a ratio of time the machine inhales and time the machine allows for exhalation. Ventilators typically represent these numbers because we don't want to give you less time to blow out than you breathed in. So it's known that we want one part in to longer than one part out. You may potentially see a ratio of 1 to 1 or 1 to less than 1 during a period of time when your child might be very upset or anxious and breathing really fast for a brief period of time. But it's unlikely that you'll see that often. The peak flow is just telling us that, the highest amount of flow that last breath achieved with the ventilator. Nothing for you to set or adjust. And again, we've talked about minute ventilation. So this 7.1 liters per minute you see here should be the respiratory rate of 22 multiplied by the breath sizes. And remember, we have the breath sizes that are around 400 cc's of air. So think of a 1 liter bottle of seltzer. Half of that, or a little less than half of that, is the size of your child's breath when they receive the 470 or 480 cc breath. And then the pressure support breaths are a little bit less. They're in the 200s we see here. So that comes out to the 6.6 liters. These are just numbers for you to know what they are so that we know if they're different when something changes. And also for those helping care for the child, whether it be family members or nursing staff, to know what is normal awake and what is normal asleep for your child. Let's talk about the battery power a little bit more of this machine. You see some in this lower level. Well, we see a lock button there. That means we're on non-limited view, so anybody can go in and change anything right now. Typically, the machine will be locked so that you can see the settings, but you cannot change them. So with regard to power, we saw the battery in the back. That's represented by the detachable battery here and the internal batteries here. Both are full and green, as you see right now. If I remove the power from the wall, a couple of things will happen. You see the green light that we pointed out in the beginning is now out. So we know right now that we don't have external power. We also see the yellow low priority alarm lit, and we see yellow in the alarm window. AC power disconnected. Is the machine still functioning? Yes, of course. It's on battery power now. So if I accept this and say reset to get back to the main screen, we go back to our main screen that we've been looking at, but we see that there's a box now around the detachable battery. So we're using the detachable 3-hour battery right now. So what if I remove that? Here's the 3-hour battery. I've taken it out. Detachable battery disconnected. Reset again. Now we're using the internal battery. When this is depleted to a certain percentage, it would certainly notify us. There are about 15 pages in the manual with regard to power, so you're welcome to sit down with a cup of coffee and take a look through all of those. You can safely assume when you see this light lit that you are on external power. Now we see that we have both batteries, the 3-hour, internal and external, detachable, connected. And now we'll put the power back on. The green light shows us that we're on external power. Now this doesn't know whether you have a generator to your home, but we know we're on external power, and it's up to you to know how long that external power may last. The machine will certainly, as we just demonstrated, show you if we are on the internal batteries for any reason. And will, like I showed you, the yellow low priority alarm that shows up here and also in the window. So you might say to me, well, what about my patient comes disconnected off the machine? What's going to happen? So now you see a red alarm, low inspiratory pressure. This turned red, this turned red. The situation was taken care of. Somebody put your child back on the machine. They came off, it alarmed, the alarm was rectified. So there still is a menu here showing you that at 3:24 p.m. today, there was a low inspiratory pressure alarm that is now resolved. You can also silence the alarm so that you don't hear it when the child becomes disconnected, but the machine still shows you the red. If you hit the silence button and go do something, it will take the 30 seconds or so for the machine to go back into full alarm mode and let you know. So you don't want to do that when you're going to leave the room. Most people do tend to silence alarms before they're going to disconnect to keep the home quiet and not get the child or anybody else in the vicinity anxious about an alarm. So you see here we've got our menu. That can be erased, not if you're on limited menu view, but when your practitioners come out to your house, they can clear this alarm history for you. I'm going to just go to reset and go back to the main screen. So this is where you're going to keep your screen, where you see the breaths happening, where you can see the tidal volumes and the minute volume, where you can see the respiratory rate going on at that period in time, and you can see the trigger. Did my child initiate that last breath, or for some reason are they really sleepy? A lot of children do go home from the hospital still with some sedative medications as they continue to recover. Perhaps there was an extra dose of sedative or something that changed your child's drive to breathe. You might notice that there's less of the light triggering, possibly. So one more subject we need to tackle here is water in the ventilator circuit. We do, for patients with small tracheostomy tubes, do hope to keep the secretions moisturized and humidified so that there is less risk of plugging of the tracheostomy tube. In the adult world, very few use the heated humidifier system that you see here today. They tend to use devices like this one, which is called a heat moisture exchanger, and this captures moisture of the air that you exhale and attempts to give the heat and the moisture that it's captured back to you on the next breath. This is used in children. We have a couple different sizes depending on the size of your child and their breath. These are used in children when you leave the home and go out for the park, medical appointments, etc. When you leave the home, and we'll show you that shortly, that this would be used and not obviously taking this humidifier system with you because it's rather bulky. And if you spill the water into the hoses, that would not be too fun for your child. The humidifier technology is advanced to the point where there are temperature probes that look at the temperature of the water and the air coming out. They look at the temperature up near your child's tracheostomy tube, and they do their best to disallow the ambient room temperature, which might be 65 or 70 degrees, from affecting the air and the heated air that we want to get into the tracheostomy tube at 98.6 or body temperature. It's not a perfect system. It's affected by air conditioners, heaters. If you put a warm water bottle because your child had a tummy ache and it happened to be on the probe from the heater system, it might read that the air is warm, but in fact it's really the hot water bottle that's seeing the warmth here. It's important to keep the water out of the tubing as much as possible. What you may notice is that when water builds up, the tubing starts to move. And when the tubing starts to move, it can falsely tell the ventilator that your child wants a breath. At some point in time, your child is resting comfortably and you notice that the respiratory rate on the ventilator seems to be quite high. And you do look at your child and the chest is going up and down. But you look again and see the tubing moving. The tubing will cause false initiations of breaths from the ventilator if there's quite a bit of water there. Another situation in which you might see this is if the child has an uncuffed tracheostomy tube or a tracheostomy tube that the cuff is not inflated during sleep. The larger the leak out the nose and mouth, the ventilator may, if not set properly, the sensitivity not set properly, may what we call auto cycle or auto fire breaths. So please do consult with your DME, durable medical equipment company therapist, and or whoever's following your child about potentially adjusting the ventilator's sensitivity so that it doesn't do this auto-cycling phenomenon. So in one situation, you drain the water, that's easy, the water's drained, the respiratory rate comes down. If you're dealing with an air leak out the nose and mouth, either due to an uncuffed or a cuff that's somewhat deflated, you may desire to have that for a reason. Your child may want to call out to you in the middle of the night and needs the cuff down a little bit. There are ways to make different adjustments for the ventilator to help so that you can have the cuff down a little bit and still not have the ventilator misfunction. So now I think what we're going to do is change over to the different types of different circuits for the Triology. We're going to talk about the passive circuit, and I'll change the machine to the passive mode so we can look at that. What the Triology, because it has BiPAP technology in it, it can compensate very well for leaks. Because remember, BiPAP is when you are anticipated to have a mask on your face, and the mask might move and has leaks. So BiPAP technology is made to do leak compensation. So if a patient has a tracheostomy tube without a balloon or a cuff on it, the Triology typically does very well with those patients. Not having a cuff is desirable by the family, and certainly the otolaryngologist caring for that child if possible. I'd like to show you now the passive function of the Triology 100 ventilator. We looked at the active circuit, which had an exhalation valve within the circuitry in which the patient inhales and then exhales out through the tubing through the exhalation valve, which generates the positive end expiratory pressure, or PEEP, and controls the breath cycles. This right now, what you see is the same filter coming out of the machine, sending the air through the humidifier, out the other side, so it's picking up heat and humidity. There's a wire within the circuit that's attempting to keep the air warm and moist as it travels to the end. So we have a single hose. This is a place for a humidifier temperature probe, and this is the proprietary, what they call exhalation port or whisper swivel. This is where air or exhalation gas comes out. So what do we do with this? We can hook this to our mask. We can hook this to our tracheostomy tube. If the mask for home use has a place where air vents out, so it should be known as a vented mask with an exhalation port of some sort in it. We only need one place for the patient to exhale carbon dioxide. The preference would be that it be in the mask. So these little star type holes that you see here, this is where the air would come out for this patient. We would be able to directly hook up the mask to the hose. We would not need a secondary whisper swivel. This is another mask, a nasal mask for an infant. This has exhalation right here and holes in the mask, so the patient's carbon dioxide will be flushed out through these holes. This could again be directly hooked up to a circuit from the machine. It would not need the secondary whisper swivel. When a patient is being connected to a tracheostomy tube, they don't have the extra places for the air to come out. So they need this whisper swivel or exhalation port in the circuit as close to the tracheostomy tube as possible for when they exhale. Unfortunately, the way the tubing is made, we do need some adapters. So we have an adapter typically known as 2222 millimeter for the size of it. And then we take it down to what's known as a 1515, and then it will fit directly onto the tracheostomy tube. Now this might be a little cumbersome and stiff, so we are allowing folks to use, for the younger population, the smaller swivel, and then we do have the larger swivel as well that I showed you earlier. For flexibility, I'm going to hook up our now passive pediatric circuit to our test patient, and we will turn our machine on and see what that looks like. So one thing you'll notice is we no longer have the two lines hooking up to the active points in the rear of the machine here. Those will be missing if your child is on a passive circuit. The advantages to a passive circuit, one would be that your child was on a BiPAP mode to a face mask, either full face or nasal mask. You would use a solid hose directly to the mask, and the venting should be through the holes that are made and available in the mask itself. Some of our folks like certain types of masks that may not be vented, in which case you do have to keep the exhale port here on the machine. We need one exhale port, either in the mask built in or in the tubing. So for a tracheostomy patient, it's in the tubing. And like I said, we need a few adapters to get it to fit the tracheostomy tube. Over here, what you'll see on the machine is that it now says ST. The mode is up in the upper left-hand corner. ST stands for spontaneous timed. That is a type of BiPAP setting. This machine could provide CPAP, which is a standalone positive airway pressure to help keep the lungs open between the breath cycles that one takes on their own. It could be in the spontaneous mode, which means that you receive the help of non-invasive ventilation or BiPAP, assistance with your breath size, but the machine, if you were not to breathe, would not fire. It would wait for you. What we typically use for infants and children who require what you might call pressure support because it's to a tracheostomy tube, or BiPAP if it's to a face mask, is the spontaneous timed mode. This allows for a backup rate in the event that the patient doesn't breathe above a certain rate that you set. What we find in young infants and children and those that are weak, those particularly under maybe 2 years old or so, they have difficulty during times of illness or due to their size in triggering or turning on a breath. So right now, when you look at the machine, you don't see that little black ball. So right now, this patient is getting breaths, getting pressure support or BiPAP breaths, but they are not triggering them themselves. And we'll review the settings, but right now they're not taking them. So if I start assisting, there we go. So this patient can breathe as fast as they want to, but currently the breath rate, backup breath rate, is set at 20 breaths a minute. So if they breathe below 20, the machine will fire. So if they go to sleep, they're very quiet and calm, you'll no longer see the ball. What we find in these young, weakened children and infants is that because they're unable to trigger the device at times, we need to set our backup rate higher than you would think. For the adult population, maybe they would have a backup rate of 8, even the teenagers, those that you know can trigger the machine. But if we find that our patient cannot consistently turn the breath on or trigger the machine, given the setting that's on there, we will set a rate slightly below their sleeping respiratory rate so that they will be able to receive the benefit of the assisted breaths or the BiPAP breaths. What we see here on our patient now is we see, and from what you learned before, you should be able to tell me, this patient breath goes up to 15 and down to 5. You see it here in the bar. You also see it here, pressure, up to 14.6, down to 5. So you should be able to tell me that this patient's on pressure support or pressure ventilation or BiPAP based on this mode, and their numbers are up to 15 and down to 5. But let's look in the settings and see for ourselves. So we're going into the menu up button right here. We'll go into the menu and we're going to go into settings and alarms. If the machine is in the limited view, you will go into the information button to get your information. But here we can go into settings and alarms. We're going to select them, and we're going to see that our mode is ST, which was visible to us on the face screen of the machine. We have an inspiratory pressure of 15, as we noted from the screen out front. We have an expiratory pressure of 5. So you might say to me, well, that says PIP and that says IPAP. What's with the language? The BiPAP world uses the terms IPAP for inspiratory pressure and EPAP for expiratory pressure. The ventilator language is pressure support and PEEP. So there are some nuances to how we verbalize them. So we're using a BiPAP mode, but we're using it on a tracheostomy tube. So you might say, well, she told me tracheostomy tube is pressure support and mask is BiPAP. So the Triology allows us to use the BiPAP mode with a tracheostomy tube. It is FDA approved for 5 kilos and above, and can provide the support, and the patient doesn't necessarily have to have a cuff on their tracheostomy tube. If the leak is really large, sometimes we found that the cuff is necessary. But typically you can have a patient, and the scenario typically is that a child's home with a tracheostomy tube and maybe has some respiratory distress or pneumonia a few times, and the providers feel, well, maybe we should support this child at night, and we should offer them a little bit of help with their breathing cycle when they're sleeping, because typically we all breathe a little more shallow during sleep, and this child with their breathing problems and or lung or muscle problems, we think this child probably could use a little bit more help at night. So we're going to implement the Triology. And we can do this without changing the tracheostomy tube. The family may be very comfortable with the tracheostomy tube that they have in place and don't want to add a cuff to that. So this gives us that option as well. We have some families, some children who maybe they're on a tracheostomy tube now, but they're doing better and they're thinking about going to BiPAP with a mask and getting the trach out. So we cap the tracheostomy tube and put the mask on their face. So the machine is versatile in that it can do many different things for the children. And it's helpful sometimes to have the family learn this, and then when they go to BiPAP, they already know the machine. Although there will be some changes, it won't be like something very new to the home. So we're just watching that our patient today is getting assistance of up to 15 and down to 5. So the 5 would be the PEEP that is ordered by your physician, an amount to help keep the lung expanded between breath cycles. And the amount of help that this child needs is up to 15 and down to 5. That difference is 10. That's just math. But remember that there's that language situation between, is my child on pressure support or is my child on BiPAP, and how much are they on? So depending on when you go in and out of a hospital facility, they may use a different device than the Triology, and it may do the support differently. So if you were to come to Children's Hospital and go onto a ventilator with a tracheostomy tube, they would call it pressure support, and the numbers you give them might make it a little confusing. So try to remember that it's up to 15 and down to 5. And I've been advising folks that I care for their children of to take a picture. If they have a smartphone that takes photographs, take a picture of the front of the machine so that you can have the numbers right with you. We can certainly write them down and put them on your medication list in your bag that you take out with you when you leave the home, but it seems that these days everyone has a smartphone that takes pictures. So you can even take a little video clip of it running so that the caregivers can see. Now you might say, well, I'll have my machine with me and they can look at it. That's true, but the place that you go, perhaps they don't understand the Triology or they're not comfortable with reading off of it. That's a possibility. And also, many children are on support at night, and they might come to the hospital for a medical appointment, but lo and behold, something required them to stay. So your equipment's at home, and now you're at the hospital and you don't have your machine, and people are asking you, well, what kind of support is your child on at night? So it's nice to have a picture of it in your smartphone. I'd like to show you how you travel with this machine out of the home. So we're not going to travel with the humidifier, as that is bulky, has water in it, etc., for obvious reasons. So the Triology company does make several different circuits. This would be an example of the passive circuit without humidification. So this circuit, I merely am going to disconnect the humidifier . So this is now completely disconnected from us, and I'll connect it to our child for today. So now we have a circuit that easily connects from the machine to the child. This can be in the carry case that I showed you earlier. Your oxygen's connected in the back. So depending on what your child's needs are for leaving the home, and this includes non-invasive ventilation by mask. You would have a solid hose that went right to the mask so you can travel safely in the car knowing that you have battery backup. In addition, for patients with tracheostomy tube, we can add the heat moisture exchanger that our child will have the advantage of the heat moisture exchanger, which will gather heat and moisture from the patient's exhaled air and try to give it back during inhalation. So it's not quite perfect system, not like this at home, but typically works very well. The tolerance for this, just try increasing the time that your child uses this device. And I do need to point out to you that the size of the device does matter. This would be a neonatal infant device. This would be for a child. They come very large, but remember that this is where your child is. This is where the fresh gas is exchanged. So a great big heat moisture exchanger could create too much distance between the fresh gas and your child's body. So we need to make you aware of it. The reason I tell folks about this and stress it is because things will be shipped to your home and they may ship you the wrong products and they may look good to you because they give you more space and flexibility, but they may not be safe for your child. So talk with your therapist and your physicians about what equipment comes to your home, and don't use something that looks unfamiliar until you get it approved for use. So the heat moisture exchanger gives freedom from the home to children with tracheostomy tubes on ventilators. Let's review alarms for the Triology ventilator. This is somewhat of a cheat sheet that I created from the manual. As noted earlier, there are a lot of alarms. What I did was make this cheat sheet so that folks could post this on the wall in their home for the nurses and caregivers to have nearby. And not all of these alarms apply to each one of your children. It depends what mode they're in on the ventilator and what alarms are turned on and enabled. You saw earlier that we have battery alarms that certainly are not turned off. You saw earlier that we had a disconnect alarm as well that came up as red high priority. So some of these alarms will apply to your children and some will not. When you have a mask on your face, if the child pulls the mask over to their cheek, the machine's still going to ventilate their cheek. And the machine may not know, because it isn't a disconnect, there's still a solid surface behind it. It doesn't know how much air goes in and out of your child unless we're looking at the volume numbers on the machine. Once you're more familiar with the machine, if you feel comfortable with some of the numbers that you see there, alarms can be set, such as low respiratory rate, high respiratory rate. The machine also alarms for minute volume. We talked about minute volume being how many breaths your child takes and the size of them, and the machine's looking at that number constantly. The oximeter is also an alarm for you for the safety of your child, looking at heart rate and oxygen saturation, so that you can use these to help. Over on the machine, if we go into the menu, we can go into settings and alarms. The alarms are the same for all the different modes of ventilation. It's up to the caregivers and the family and the providers to determine which alarms are appropriate for your child. So we have our first alarm is circuit disconnection, and we can set time in seconds until we will know that the patient is disconnected. So what you see here is what you saw was low inspiratory pressure. That's an internal alarm. There are some alarms that we actually set and some that are set internally by the company. Then we have an apnea alarm, so that if your child does not trigger breaths with that little circle that we've pointed out to you earlier, the machine will alarm apnea in a given number of seconds that we set on the machine. So remember that when a child's on a ventilator and they rest at night and they don't trigger breaths, that will make the apnea alarm go off. So the apnea alarm may not necessarily be used in all patients, even though it seems like intuitively you would want to use an apnea alarm. We can look at the size of each breath and alarm for low breath size or high breath size. We can look at the minute ventilation, here 2.9 liters, and we can alarm for high and low minute ventilation. High might tell us if there's crying or high respiratory rate, a lot of breathing. Low, breathing more shallow, perhaps secretions building up. But remember, these are alarms to help us troubleshoot the situation at home, and we need to look at the given activities. So sometimes during the day there's a lot of therapy in which the alarms go off a lot, and at night we'd like them to be a little bit set a little bit more judiciously to help us so that we know if something's wrong. We have low respiratory rate and high respiratory rate. And that's it for the alarms on the face of the machine. There are other alarms that are internally set, like high and low pressure based on the mode the machine's on and the pressures. So please just ask your therapist that's helping you set up this machine at home which alarms are set and for what reason. And when you do get alarms at home, let's work together with your practitioners and your respiratory therapist from your DME company to determine what alarms are going off and why, if they're appropriate or if the settings need to be adjusted. Respironics has added some features to the Triology 100 and 200 ventilators. You see the Triology 100 ventilator here. As you can see on the screen, they have now added a graphics page which can be used to monitor your patient or your child. In addition, there is a nebulizer on-off feature. When you turn the nebulizer feature on, it is disabling certain alarms that would normally audibly alarm because you've added flow to the circuit. So the Triology does not provide the nebulizer treatment, but it can accommodate alarms so that if you add a nebulizer treatment in line to the circuitry, for example, giving your child albuterol for about 5 minutes, the Triology will accommodate the extra flow that you've added into the circuitry. In addition, they've added to the sensitivity options or triggering options, meaning that when the child tries to initiate a breath and you see that little black or gray ball in the upper left-hand corner, there is now a sensitivity feature called AutoTrack-sensitive instead of just AutoTrack. So the options for sensitivity are flow trigger 1 through 5, 1 being the easiest, AutoTrack, and AutoTrack sensitive. The next improvement they've made is with the adjustable AVAPS mode. So if your child is in the AVAPS mode, your clinician can now determine how quickly or slowly the ventilator will adjust the level of pressure that's set in the AVAP parameter, and how quickly that will adjust to the high or low parameter that your physician has set for your child. The last added feature to the Triology 100 and 200 series ventilator is the ability to use it for mouthpiece ventilation, which means that your child can use the ventilator, presumably during the day when up and about, for breaths with a mouthpiece that would be positioned near their mouth, and they could merely turn their head a slight amount and utilize the machine breaths with a mouthpiece and release to talk or eat or drink. This is a very desirable mode for patients, especially those with neuromuscular disease who may wear a mask overnight but during the day need some help but don't need to wear the mask all the time, or simply want their face to have some time with the pressure off of it. The mouthpiece ventilation is available in volume and pressure control modes. Work with your respiratory care practitioner and physician to determine what settings are most comfortable for your child with mouthpiece ventilation. The Respironics company does have specific part ordering numbers, one that provides you with the actual mechanical arm to hook to a wheelchair if the child is in a wheelchair perhaps, and hold the mouthpiece near their mouth. In addition to that, they have the circuitry, which would be provided by your durable medical equipment company. Thank you for participating with me today on this educational opportunity for me to help you with the Triology 100 ventilator. I hope this has been helpful to you. Please do ask questions of your providers when you have them and help determine what are the best supports for your child and what are the best alarms that can help keep your child safe and not keep the household up all night. We did review the Triology 100 in both the active and passive types of circuitry. Remember, there are many different types of circuitry, pediatric and adult, heated and non-heated, so determine what's best for your child. When using a mask, you do not necessarily need the heated humidifier. In the adult world, people tell us they don't like the hot air. So your child may not be able to voice that to you, but may not like the hot air. When it comes to a tracheostomy tube, we do provide heat and humidity for our children because their tracheostomy tubes are smaller than the adult tubes typically, and we don't want any risk of plugging. We'd like to keep the secretions thin. So I hope you enjoyed this, and I hope it was helpful to you.